So I don't think most people actually have an issue with overpronation. They have an issue that they pronate too fast. So it's too rapid and the force doesn't get absorbed, or they're losing the range where they can absorb force.
Welcome back to another episode of Past Your Prime, the podcast for active adults balancing training, rehab, family, and real life. I'm Alex Keicher, pro volleyball player, working father, injury collector, Hall of Fame inductee, here with my favorite physical therapist, Craig Smith. He's a coach, life professional, and far beyond 75 hard. Today, we're tackling a different issue, though. We're talking about shin splints, shin splinties.
Shin splints.
So this is one of the most common and frustrating injuries for runners and also active adults, but mostly runners. So I'm an active adult, and I don't think that I've ever had shin splints. Knock on the wood, because I'm probably going to have it now, because that is the history of this podcast, that any injury we talk about, I end up with. Although we didn't talk about random elbow injuries, and I got that too. So anyway, you might have had them. You might know somebody else who had them, or they've been told that it's just a part of running. But Craig is here to break it down. Really quickly, we launched the Past Your Prime podcast Instagram. So as you're listening here, log into your IG, type in Past Your Prime podcast, and hit that follow button. All right, back to business. What are shin splints if they are not large pieces of wood in your shins?
Well, it actually can be a whole bunch of different diagnoses, which means it's a garbage term.
Is shin splints a diagnosis?
It is not.
Man.
I honestly wonder where it came from.
Is it just like tightness?
God.
It's not a
like
diagnosis?
It's another one of them where I think the diagnosis, it's just not specific, and it really just describes where, or like maybe the location of the symptom, or the location of what the person is experiencing, which is more in your lower leg and specifically on the inner aspect of your lower leg. I'm not sure why. I actually probably should have looked that up, what the origin of it was. Partially, I think it's that it feels like your bone is splinting from from where it's supposed to be.
And this is mostly runners, like how like you're not doing an infinity number of tib raises and getting shin splints.
Well, it's not. It's definitely anybody who is involved in running. So it's really common in like basketball. It's really common in football. Really common in
like soccer.
So I see it a lot. I see it a lot, especially early season, where people will initially develop it. But there's also kind of this subgroup of individuals that seem to get it anytime they build volume, and it almost seems like it never goes away. So if they get past a certain point of I participate too much and I'm gonna start to hurt, and it just keeps on recurring over and over again, those are the individuals who get this term shin splints, and then they get taught things. If they don't address actually the root issue, they can get stuck in this permanent hell that happens with shin splints, because they suck. Like the actual experience is painful.
Well, and from my experience with runners, those folks are generally addicted to running, so they just never stop either.
Yeah. And if you don't figure out the specific reason why it happens, it becomes a really irritating injury.
Okay, so you said it's kind of this weird bony pain. What in your clinical experience, what is the pain generator coming from?
I think the biggest thing is to really know what structure is actually causing the pain. So I think of this one in two ways. You really want to understand what the pain generator is, and you want to understand the functional cause of it, which are two separate things. Most commonly, you're dealing with a medial tibial stress syndrome or stress reaction, possibly a stress fracture. That's going to be where the bone on your medial tibia, it's exquisitely tender. So if you're sitting at home and you're not sure if you're feeling this, you basically feel on the inside of the tibia and you just basically pressure it, and you'll find a spot that'll be point brutally tender.
I have no exquisite tenderness in my tibia.
Man, this is cool. So we actually found one that Alex does not currently have. But yeah, next week you're going to have it. Yeah, shin splints.
I've been thinking about trying to run again because everything else is feeling decent. I know that'll just put me into another hole, but...
You know what's funny about that? My dad wants to coach you for running.
Come on, Papa Smith.
Yeah, yeah.
Coach me up.
He was just here. He wanted to meet you, and I was like, "You're not meeting Alex, Dad."
You guys will become best friends, and then I'll get kicked out of the equation.
All of a sudden, my dad has my spot. Yeah, that would be awesome. I'd be like, "Wow, Dad,
Yeah,
come on, man."
Papa Smith podcast.
Yeah, but probably would blow up. To be honest, it would be
Sounds like a cool guy.
yeah, what successful anecdotes of treatment could we use for this person? You know, like you'd be like, well, what you do is I don't know what you'd say.
Go running.
Stretch it. Yeah.
Mm.
Back in my day. Okay. Anyway, sorry, Dad. That's the most common one. Medial tibial stress syndrome. Posterior tibialis tendon injury is the next one, like the post tib, because it's the muscle that has the best leverage to control pronation. So it's one of them that's just going to be subjected to a lot of stress, a lot of load. Next one you're looking at is going to be soleus in your gastroc, so your calf muscles. And those ones, it's actually not typical that the muscles hurt. It's often that it's becomes overactive.
Those could
Yeah.
pain in your calves essentially could cause like a weird pain reaction in the front of your leg.
Well, that's
Because when I think of shin splints, I think of just pain in the front of your leg.
you would think that, right? Like you think of it in that kind of inside part of your lower leg, but I've had people come in where it's on the very front, like more over their pretibial muscles.
Yeah.
I've had it where the person was diagnosed with shin splints and it was a calf strain. That's why it's not a specific. It's
What
not a
idiot
specific
diagnosed
diagnosis.
that?
Well, I also think there's also sometimes where the person is self-diagnosing and they say they have
Okay.
shin splints. I don't really like the term shin splints. It's just a very common one that people will come in with, but that is the issue. It's not specific.
Okay, what else could we be getting?
Stress fracture. You might be having the soleus and calf, like I talked about. Infrequently, you have your flexor hallucis longus. You can have a referral from your low back. And the final one that I always think of is you want to rule out nerve.
So that was like 7 or 8 things that are all kind of misdiagnosed as shin splints.
But the most common are those first two. What's funny is the pain generator matters. It always matters. You want to get as close to it as you can. But this is one of the rare ones where it's actually functional diagnosis that's way more important.
Okay.
Dramatically more important, which actually kind of leads into why people get it.
And then the exam would kind of lead you through which one of these it could be.
Yeah, so when you go through a specific exam of the lower leg, the thing that's really diagnostic on this one is going to be, if it's the first one, the medial tibial stress syndrome, you're palpably tender on the bone. The way the lower leg is set up, there's what's called a crural fascia that connects to the bone. That's where the stress happens. It's a fascial connection, but it's the bone that gives that characteristic gross pain. Because bone hurts. When it hurts, it really hurts.
Exquisitely tender.
Exquisitely tender.
Okay.
Nauseatingly painful.
And I think I just alluded to this, but more specifically, why do people actually get shin splints?
Well, and this kind of goes with the functional exam. So this is where, if you guys remember, we've talked about how we think of diagnosis. And the way we think of diagnosis is 4 pillars. It's structural exam. So we can do this test and we can find the thing that hurts and I can recreate it with the exam. Another one is functional. And the functional exam is actually more important, in my opinion, for this type of a presentation. You can also have a treatment response. It's how they respond to treatment, and then trigger management. You can have one or you can have all 4 where you're really clear on it. The more you have, the typically more confident you are in being able to diagnose and treat. Well, I want to be specific on how do you identify if it's either a medial tibial stress syndrome or if it's a post-tib injury. So if you're at home, if you feel along the inside of your tibia, so like I'm sitting here and I'm coming up the leg, if I just palpate that and you're tender on the bone, it's a medial tibial stress syndrome.
I don't have it.
Well, if you're hypertrophied in the calf like Alex is, his muscle actually folds over the front of his shin in this kind of grotesque muscular way.
I can feel that.
So you may not have that problem. But if you feel tenderness on bone, you're probably dealing with the medial tibial stress syndrome. Now to resist the post tib, if you cross your leg over the way that Alex is kind of doing behind the computer right now, and you take and you push down on your forefoot, that lowers the post tib. So if I'm like sitting here, that's your post tib. If that hurts, like if you all of a sudden you have pain with that, you have a post tib injury.
That feels good to me.
That feels good.
It does.
Yeah. You can also test it by doing a single leg calf raise.
Well, and you've been having me do those tib raises as a part of my warm up. So like I can feel that like trying to creep over to the other side.
Well, so the pretibials are also ones that help control pronations. That makes sense. But your post tib it's just the most commonly injured, and because of its ability to absorb force with that motion.
Talked about force absorption a couple of times in the podcast before, and so for whatever reason, my mind goes to like quads and lower legs and
What should?
yeah.
Yeah,
Okay.
good job. Yeah, yeah. So quad is the most important force absorber and oftentimes gets ignored because there's been a focus more towards the glute, which is understandable, but quad is incredibly important. And when I say force absorption, we're talking about the lower extremity. It's any muscle that's involved in basically absorbing the force when your body comes to the ground. So when you go from like a flight phase, if you're running to where your heel hits or your forefoot hits, and you start to absorb the force onto that single leg, a force absorption issue is where instead of the muscles and the structures that should be absorbing force absorbing it, something gets off. It's actually really kind of interesting. Like when you're running, it's the joints that are absorbing it, your soft tissues, your connective tissues, and your muscles and tendons, like they're all involved. And if any one of them gets out of sync, you can absolutely compensate, but eventually what happens is you can't compensate for the absorption issue, and you basically transfer the force to one of these structures. So you can have an issue where it's actually being driven by your foot, but it causes an injury at your hip. Or you can have a hip issue or a back issue that drives an issue distally. Like there's all these like interconnections. So when I say force absorption, you're not absorbing the force you're producing.
Okay. And that could be, that's generally running though, is where you see this.
Oh my God. Yeah. 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 So this is by far the most common one is going to be running. With running, there's three things that you need to be able to do. So the first one is your joints need to be able to flex. So like your hip joint needs to be able to flex, your knee needs to be able to flex. And then we call it at the ankle, it needs to be able to dorsiflex.
And
So,
if this is your first time listening, you should stretch for those, right?
oh God, no. God, Alex is joking. If you start to stretch, I don't I don't think stretching is valuable. I do believe in mobility work. I do believe in making sure that you can maintain your ability to move, obviously, but I think stretching is overweighted and overvalued. On that note, though, you do need to be able to produce an internal rotation of your hip and knee, and then from there, you need to be able to pronate at the subtalar joint and through the midfoot. And if you can't do any of those motions, you're basically going to be too stiff in those joints. So that'd be the first thing, would be the range of motion. And then the next one would be you have to be able to control internal rotation at the hip, flexion at the knee, flexion at the ankle, and then pronation at the subtalar joint. And if you can't control any of those, you're going to overload structures. And then sometimes that's going to show up as a shin splint, which could be a variety of different things causing it.
That, yeah, that you just basically named every single area in the lower leg.
Which is, I think that's important to remember, right? So if you have a force absorption issue when you're running, it can present as almost like an unbelievable amount of injuries in your leg. That's why force absorption is the primary issue with most runners. That's why, like, if you're treating a runner and they want to get back into it, if I want them to run immediately, I just basically make it so they can absorb force better. That's why it's not that difficult to get a runner to run again. You always assume it's a force absorption issue. You can make them run uphill. You can put any level of brace on that's going to help with absorption. That's why the modified lodi, the taping, there's like all these like tools that you can use that can be used as a crutch or even as a load manager. And it works really well because almost all lower extremity injuries are force absorption errors.
Okay. So you were starting to allude to treatment there. What does treatment look like from your perspective when it comes to the shin splints?
The rest of this stuff is actually fairly simple. You want to do a specific treatment to make that tissue, whatever's hurting, feel better. When it's a medial tibial stress syndrome, I think it's going to be very difficult for you to make it feel better with tissue work or even with exercise. That's where I really like to default towards using a brace or tape or something basically to help support your pronation. And I think one of the big things that happens is they think that there's something wrong with pronating. Have you ever heard of that before? People will often say they overpronate.
Like too much internal rotation or
So yeah, it's like they'll say they have like flat feet and they'll go into a shoe store and they'll basically get like a really rigid shoe or something to help manage pronation. You're supposed to pronate. Like pronation with internal rotation, with flexion in the lower extremity actually allows you to absorb force. And if you shortchange it at any place, you're basically reducing the runway for your body to absorb force.
You just kind of like stomping, putting pressure on
Yeah,
that
yeah.
front leg area.
Yeah, because if you kind of think about force absorption, one of the ways to absorb more force is to do it over a longer range of motion, right? So you can absorb more and it's less stressful. Another way is to give yourself more time, so the rate that you absorb the force. And what I find happens is people will start to cut off their ability to absorb force either by reducing the range of motion or making it way fast. So I don't think most people actually have an issue with overpronation. They have an issue that they pronate too fast. So it's too rapid and the force doesn't get absorbed, or they're losing the range where they can absorb force. And that's actually really, really critical. So after I do like a specific treatment to somebody, then it's all about normalizing their force absorption and whatever their error is. And remember, this is actually the part that I think is the most tricky. So if you're somebody who has this happen over and over again, you treat it, it comes back, you treat it, it comes back. You've never fixed the absorption issue. And it can be the whole leg. So you might have weakness in your quad that's driving a shin splint. You might have weakness in the glute. It could be the post tib, it could be your calf, it could be your plantar intrinsics, or it could be that your motion is too restricted. So it could be any of those things. You have to figure out which one it is. And if you keep on having it over and over again, you're not fixing it.
You had talked about taping methods there. Are you talking like foot taping, ankle taping? Are you KT taping just your whole leg, wrapping it in KT?
Yeah. So you're not definitely not wrapping the whole body. My go-to, if I have to go up the leg, it's going to be, if I'm looking at the bottom of the foot first, modified Lodi. And so what that's going to do is it basically takes your foot and it's going to support a lot of muscles, but it increases your arch height.
Did you do that to Audrey last week?
I might have. It's really helpful.
Okay.
It's helpful because
You had done a foot taping and I just wasn't sure what it was.
yeah. That's probably my favorite, and it's one of them that we've actually done research on. We found when we looked at people with this, when we do the taping using the stiff tape called the Leuco tape, that it lasts 5 days. And prior to the study that we did, the normal was 2 hours.
Wow.
So you start to see that the tape loses its ability to support anything after 2 hours. And what we found, and I basically had gone through a lot of iterations with using these different type of taping methods, and you can't do a normal taping with a leuco tape. You can't be as restrictive, because how normally it's done when you do a Lodi taping is you really modify how the foot structure. With this one, if you do it with like a stiff tape, it rips their skin off.
Yeah.
Like it's intolerable. And even now, having done thousands of these tapings, I will still sometimes put it too tight on the person and they'll put their foot down and they'll seem shocked. Yeah, because it doesn't seem like it's that intense when you do it, but they'll feel super uncomfortable in their leg. But that's my favorite one. Sometimes what happens with shin splints when you do the exam, you can't tell what the pain structure is. They have to run, and then they'll have taken like 2 or 3 weeks off when they come in, and they'll say, I've had a history of this issue and I'm not sure what's going on. So I have a decision to make. Do I just want them to trigger it? I would say go run. And then they come back and it's still pain free. Okay, well, I'm going to see you in a week. You're going to ramp your running right back up to where it's painful, because it's kind of counterintuitive, but it's way easier to treat when somebody feels terrible.
Well, yeah, because then they can tell you where it's hurting.
Exactly.
Yeah.
Yeah. And that's like a real clear sign of fake improvement, when every time that you take time off, it gets better. But as soon as you ramp it back up, you're getting worse. It wasn't ever fixed. Like, you're having the same problem over and over again. I'll use the modified Lodi. Like, for example, if they start to do it and they don't want to wait, I'll tape it and then have them run. Say it's like, okay, if I run for 30
helps.
minutes, and that will tell us, okay, it's an absorption issue. And I won't even need to actually have the structural diagnosis in that standpoint. The post tib brace is another great one. Surf strap is a great one, but I'll use the brace on anything. Sometimes I'll do a heel lift. Sometimes I'll have them run uphill. So there's all these different ways that you can modify the absorption strategy and get it to where they don't hurt. Then you know what's going on. And then really the big thing is you have to really find if there's any muscles that are weak.
Would that be inhibition?
It could be inhibition. The last person I went through who had chronic shin splints, like decades long shin splints, and then gotten to the point where they had this pain with just walking, and they'd stopped walking. Like, basically they'd been runners. They used all the tricks and tools, best shoes that they could find. Nothing was making them feel better. And that helped for a little bit. And then it got worse again. And then walking started to become painful. And that's what they were using for exercise. And then they basically only did walking that they had to do, and it still really hurt. And that individual, they had severe atrophy, and they had some other injuries that were actually causing some of the atrophy that had been missed. They weren't really painful or limiting to this person in the same way the shin splints were. They had massive glute atrophy and massive quad atrophy that was causing the lower leg to get overloaded. So in those situations, you have to address the original injury, and you also have to address the muscles that were contributing to the lower extremity injury.
So that was probably both a little bit of strength training and activation.
You've got it.
Yeah.
Inhibitions, though, like what you were getting at, most common problem. It's not that you're actually weak. It's typically that the muscles got shut off, and that the act of running actually shuts them off.
Could running mechanics be a part of it as well? I know I run like a kangaroo, so
No, typically kangaroo running's good. So you're doing it with two legs and you're jumping forward. I like it. So if you pogo hop for running, that is obviously a problem. Yeah. Yeah.
that's probably why I'm so bad at running.
Yeah.
And
Who
maybe
taught
I
you to
need a
run like
coach.
that? Who
You.
taught you? Did I? Okay.
Yeah.
That's why we're not getting any clients now. If anybody listens, it's like, does he actively like beat him with a stick? And then he also taught him to run with a pogo hop. So actually, yeah, if you're pogo hopping for running, that can be an actual problem. Running mechanics, though, no, I don't think running mechanics are as big of an issue as what I feel like I hear all the time, like where somebody will come in and they'll be a heel striker and they think that's the issue, or they'll come in and have switched to a different type of foot strike because they thought heel strike was bad. You can strike with either pattern and not have shin splint.
What if your heels don't touch the ground when you're running?
Do your heels not touch the ground when you run?
I think when you did my gait analysis about 10 or 12 years ago, they barely did.
Yeah,
I was like a toe runner.
I feel like you were a toe runner and your knees didn't bend. So you like did this like kind of weird straight legged. It was like a Deion Sanders into the end zone. Yeah. Oh, it's fine. It's fine if they don't. We can get into like how foot strikes.
I was just
matter.
wondering if that contributes to shin splints.
It does if you're a 4-foot striker, and because you're a 4-foot striker, what you're using to absorb force isn't good enough, then absolutely it will. Like so, it absolutely will. But the same thing can be said with heel striking. So it's still a force absorption issue, and so how you hit the ground, your foot contact, really matters if that strategy makes it so you don't have enough force absorption. Does that make sense?
No, yeah. I mean, at the core of it, it sounds like force absorption is kind of the root cause here.
100%.
And if you fix that, then you can probably fix some of these pain generators.
So you can have a beautiful gait pattern and still have shin splints. Like you can have what would be considered the best form ever and still have this problem. It can get masked. But oftentimes, like once it starts to hurt, you're going to be changing your gait pattern anyway. And that's why, like I used to change the gait pattern on people a lot. I rarely do that anymore because it's blown up in my face so often. Like I've made people dramatically worse, and so we don't do it that route anymore. Gait changes are like a last resort.
Okay, we talked about tools. We talked about inhibition. What does it look like if you're trying to get back to running?
So it really depends.
Sounds like you make some people just go and run to hurt themselves worse initially.
Yeah. So step one for us getting it better, what's actually causing your pain? Number two is identifying what's the issue with your force absorption, because you have one and we just got to figure out what it is. So if we figure that out and it's like an easy fix, you're back to running immediately. I've had before where it's a session issue and then you're back to it and we just correct it as we build up your running
Like, yeah,
mileage
get
again.
your activation going.
Yeah.
And you can be good to go.
Yeah. So if it's purely an inhibition issue, like, so for example, let's say when you're running for some reason, your calf is shutting off. Most common reason would be your back is irritable. It shuts off your S1 and your calf becomes weak, right? S1 nerve root. And so you have an inhibition that's very easy for us to treat. You traction your back before you run. And then every 10 to 15 minutes, you do a calf raise to reactivate. I've had before where you ramp their volume back up. And if they didn't have that much time off, they're back to it within a week. Like that's not even an uncommon presentation. But I've also had where people have used tools to get themselves through running for a long period of time, where they've done with shin splints for a decade and they have massive atrophy. Well, that's a year to 2 to 3 year project to get you back to where you're not having to use these tools to mask your symptoms and you can run and actually enjoy running again, because you have to actually get the muscle and then retrain your force absorption pattern and then also make sure that there's no inhibition issues.
Were you able to get the case you were just talking about back to running?
Fully back to running. So I like to go, if I'm progressing somebody, I reduce force by making them run uphill on treadmill first to where they can do it and it's not hurting. And then from there, I like to work towards it being flat because you're having to absorb more force. Then after I get full volume, like so I get say they want to be able to run an hour straight, then I transfer them to outside. And then once they're outside, that's where I start to take away the reactivation periods. And then at the last thing I add back in is downhill because that's the most force you're going to be absorbing is running downhill. Well, I take that back. I add downhill, and then if they want to do speed work, that's the very last thing to add. So it's first uphill to flat to full volume to take out all the reactivation, downhill to speed work. If I had to list those six.
Nice. And just to kind of close it out, I know you had mentioned, shoes, braces, orthotics. Obviously, you don't want those to be a permanent crutch. We've talked about those things before. What are your thoughts there?
Well, I just want to make a special note on this one because I see this actually a lot, that people will use. They'll use tools that they think are just something they have to use and not realize that they've made themselves permanently reliant on a tool. We have like a belief where you have to use these tools to be able to run. Like somebody will come in, they'll be like, well, I have to use these shoes or I have to have my orthotics in or I can't run. Well, that means that you are stuck on a crutch or on a load manager forever. And to get rid of those and make yourself more resilient and less at risk for having the same injury come back over and over again, you have to address why those help you. So I always think of, we call it artificial stabilization at SBC, but you have it for diagnostics. So if the brace or the shoe helps you, that tells you something. And then you have a crutch. Crutch just means that it helps you to stabilize your symptoms and it really tries to completely unload the structure. Load manager is the next one. We use that in phase 3. We call that activity progression. Load manager basically makes it so it absorbs force for you. It supports it. That'd be like the modified load eye, the post tib brace, the surf strap. And then you have from there, once somebody is discharged from therapy, we use them as training aids. So say you're going to have a volume build, you still feel good. You might tape your foot when you're in speed work. Beginning of your season, like if you have shin splints, you might tape your foot just to make sure that the shin splints don't develop how they normally do. It's a way to disrupt your typical injury pattern as you're building fitness. And then the last one is a performance enhancer. Those are like people who will wear things that they actually put more stress on your body. So for example, carbon plate shoes, what people will use for speed work, it actually puts more load on your force absorption. So you'll have people come in with like Achilles tendon injuries because that plate doesn't move. It's super rigid and it's a huge lever on your foot.
I'm switching my shoes out to not have my shoes that have my carbon midsole in there right now. So
no, there's no issues with that.
yeah.
But what I would say though is like to go back, people will come in and they'll use like a really big medial heel post, which just means that it basically sets your foot in a position that limits your ability to pronate. And it could take load off of like your posterior tib because your post tib's not going to act as much or even give it a mechanical advantage so it can be more effective. And it doesn't address the root issues that they're not absorbing force well. It masks that they're now able to. And then a year will go by or 2 years. And that process of poor force absorption is continuing until they get to the point where that tool that was masking the symptoms no longer is effective anymore.
Right.
And so if it's so much more difficult to then manage it at that point because now you've had a crutch that I can't use anymore and it's not sufficient. So then it's a much more difficult rehab road. It's still doable, very doable, but it's just much more difficult. So if you're somebody who's listening to this and you can only run when I have this orthotic in, I can only run if I have this specific shoe, you're starting to paint yourself into a corner. You are building permanent compensations in and not actually fixing the root functional issue that is very, very critical to understand and to correct.
Yeah.
Yeah.
All righty. If you've got shin splints, it's probably not an easy diagnosis. There are a lot of different things to look at. You probably shouldn't wrap your whole lower leg in KT tape.
Or bubble wrap.
Yeah. If you haven't done so yet, drop us a subscription. Go follow Past Your Prime Podcast on Instagram. Like, comment, subscribe. Share it with a friend if you know somebody with shin splints, because you probably do. And we'll see you on the next one.
PYP, baby.
Peace.